Good morning and welcome to our monthly webcast. I'm Samir Mehta, your moderator, and this is session number 167. Thank you, many of you who have inquired about MedStream 360. They have congratulated us and even sought further information. This we will be providing to you at about 9 o'clock today at the end of the live cases. In the meantime, we have a complex coronary intervention for you today. It's a bifurcation LAD diagonal calcified lesion with a very angulated diagonal branch, and you're probably going to watch an IVUS guided complex PCI with the mini crush technique. With this introduction, let me take you to the cardiac cath lab where Dr. Kinney and Dr. Sharma are standing by. Anu, Samin, good morning.
Okay, we start our presentation. There's thankful to our supporters and the disclosures as here, nothing. Case number 167. It's a 69-year-old male, didn't have much cardiac history before and has a class 2 angina and positive stress MPI for anterior and inferior ischemia. Otherwise, good risk factor, as you see, SAQ score 45, was on aspirin, amlodipine, metoprolol, and torvastatin. And he had a two-vessel disease. We'll show it. LA diagonal bifurcation with 111 calcification and RCA. Normal EF, syntax score 29, got a PCI of the RCA with a rota plus Promus Elite, and residual syntax score 24, and was added clopidogrel. And today is our intervention of the LAD diagonal bifurcation. So just to make appropriate, clearly this case with the intermediate finding and two anti-anginals makes it appropriate for PCI. So Anu, you show it now.
We can see the angiogram.
Yep.
Yes.
So very complex plate. Yeah.
Yeah. So if
Should-
we have a EF normal, then we have the RCA, the PCI side. The stand looks good. This is where we are with the LAD. After the significant proximal mid disease, you have a small pouch ulcer.
Yeah.
There's a D1 that's occluded and D2 that's coming out through that pouch.
Yeah.
And majority of the calcium is just at that bifurcation, mostly in the main
You want to
vessel.
take a aleocranial?
No, I
Because
have
aleocranial was
I
very
have,
specific.
yeah,
Oh,
yeah,
good.
yeah.
Yeah. Look at that.
All right, as complex
think
as
we-
it gets.
Yes.
But I meant, but I don't think we want to do the PCI in this view, right?
No, wiring. Let's do the wire. So with that note, tell us what's the plan, Anu, and then you start.
We'll filter fine cross and change it to rota. I think this is the case. I know you mentioned imaging, but you would not want to
In the
image
end.
in this.
Yeah, many times, to me, imaging basically means, unless proven otherwise, it's in the end. So a lot of people decide based on the imaging. I would say imaging is the ultimate frontier that you make your stent apposition, expansion, and avoid any dissection. So therefore, from my point of view, the imaging in the end is the most important. 90% others are we decide based on the angiogram. So this patient was on clopidogrel and his PRU is 230. That's a cutoff. 230. And rest of the risk factors are very good. LDL of 56, HDL of 44. And we always check also the C-reactive protein. In all our patients, diabetic, we do hemoglobin A1C, which is not the case. And the rest of the team members with the two fellows, Udit Joshi and Vishal Dulapala. And nurses, you see all the familiar faces here, some not on the screen, some behind, and our CVTs. And of course, we have the imaging team also. Whether will need clearly interpretation in the end. Now, calcium at the lesion, you can see there, the wire is going into the diagonal. Is in the head.
That's D1.
Yeah.
What I'll do is
D1
I'll
was
get
the
fine
CTO.
cross till there, and then see if I can change it.
So, I mean, there is an important discussion here. I have noticed this, of course, as your practice. But today, for the first time, I have heard you articulate that the real purpose which you feel or the practice is post-procedural imaging evaluation. Correct?
Some die.
Yeah, absolutely, yes. Yeah, yeah. So because I think that's basically it. Because many people will decide the lesion length, whether we do a rotablation or atherectomy or not atherectomy.
Give me a
To us,
run
I
through.
think we decide based on the
Run through,
angiogram.
run through.
Right.
Those things very rarely needed. And as you know, the anatomy driven lesion MLD requirement actually is no longer indicated except for the left main. So in the past, we used to say 4 millimeter square lower could be okay for PCI, but no longer now. Everybody, it's a class 1 indication is your physiological, IFR or FFR. So decision making, except maybe the left main, where there is sometimes the rota, the our the physiology may be a little affected because of the bifurcation nature, and so and the left main there you definitely want to do a 6 millimeter square. Some people do 5.5. But there IVUS may be. But even with the guidelines, IVUS has no longer determinant for a lesion significance based on the MLD, because trial never prospectively looked into it, while IFR and FFR did a lot of uh, prospective trials to really make the validity of correlation of the abnormal IFR and FFR with the subsequent outcome.
Anu, great job with the wire. In the meantime, Dr. Savan Jalnapurka
1.5. Get
is asking,
1.5.
what is your wire strategy? Why the fielder? The answer must have become already obvious.
Yeah.
No,
The,
I mean, of course, in this kind of a lesion, when you have a 95% lesion, the first thing, and then you have that small pouch there,
Right.
you would like to use, fielder or any polymer jacketed wire should be your first wire choice, which we tried, and then in the fielder just kept going into the pouch. I had to make turn into the LED, so I changed it to run through, and I was able to get into the LED.
Absolutely wonderful handling of the wires. I mean, back to your conversation regarding, plus, of course, in addition to post-procedure, in some cases, of course, it guides during the procedure also, including in CTOs and a few other instances.
Yeah. Yeah. So I would say that the second during the procedure could be the group of CTO, but I think you need to be expert on that.
Right.
And secondly, you need an 8 French guide for to have a IVUS catheter, and then you put a parallel wire with your over the wire system to puncture where the hole, the ostium, which is not ambiguous cap, and so you'll require 8 French guide. So both are a little troublesome, but yes, those who are master in interpreting IVUS during CTO PCI have this clear advantage. I can tell you we have no advantage on that point, but a lot of Japanese guys do it. There was one small randomized trial looked into it. There was no separate benefit. So only few selected people will guide their CTO PCI with the IVUS. Now, I would say that IVUS probably is very important in ostial LED closure. Now you see, you don't see the really any nub of or a funnel shape of the ostial LED, and you see ambiguous cap, blunt tip. That case, I think you put IVUS, you look where the ostial LED closed, and then you basically puncture with your stiffer wire there. Yeah, 3030. Yeah, good. Okay,
I mean,
let's go. We don't need to check it. We just go inside, as I said. No longer
because I
check
had
the speed.
problems.
Huh?
I had problems.
Okay, so we are checking it. Okay, fine. We are checking outside. About 160 is all set, and that's where we are. You see that calcium clearly outline of the vessels. Yes. Yeah, wiring of the diagonal will be a challenge, but and then same with the rotation atherectomy, we expect there is a very tight lesion. Hopefully, it will not close, and that's what have been our data in the past.
Would you be going into the more distal of the two lesions with the rotablator, or just the bifurcation site?
I think just the bifurcation
Play,
site.
is there a calcium there? I think this is reasonable to call. No, it is there. Goes further.
Yeah, it goes
Yeah,
almost
if it
to
goes,
the
yeah, we'll do that at 3 o'clock. Yeah, absolutely. Yeah, good. Okay, we are ready with the 1.5 bar at the rota, our drive floppy.
slow pecking motion.
Yeah.
And I'm sure Dr. Kinney is going to follow it up with the polishing run as she
Yeah,
defines it.
haven't crossed yet, but yes, the key is, or can you use orbital in this case? I think we could have used orbital also, because not a little, although little angulated, we try to avoid orbital in angulated segments.
Well, almost sensing your reply, another question has come. Is IVL on the cards here?
No, IVL as a supplementary adjunct. No, IVL won't make a turn. We know that IVL,
I'm sure they're talking
as a
about
supplementary, yeah.
rotatripsy.
Oh, 100%, yes. So case is what I say. What is the purpose of the IVL? To have a good lumen expansion. So you do a then you do a balloon. If you can open it, then fine. Otherwise, you would just add a IVL. Or you can use a cutting balloon. We have done the rota cut trial. We are waiting for the data of 60 patients. Whether adding cutting balloon, you get a better lumen. We're still waiting for it. But otherwise, you use IVL if the lesion did not open. If the lesion opened it, then no.
Are you a little surprised about the challenge the rotational ablation is having here?
Yes, because of that angulated, you saw it in the
angulated,
view. We'll do a few more, and if we cannot have it, then we were going to downgrade the bird to 1.25.
Okay.
Can we, so I see it.
Nothing yet.
No.
Nothing yet.
I need to see the rotation. Make it up. It's in the bottom.
And point it towards us.
I need to see the number.
Good. Yeah, fine. Let's go. So question is, do we go, we say usually you go about 7 or 8 of them and then try, then downgrade it. Or you can go with a higher speed. Yeah, which went in.
Okay, just cross.
And
There
polish
we go.
this segment first. Yeah.
Can you remove this OCT and bring it here so I see it?
We're doing IVUS or OCT in this case.
IVUS.
Then remove. Yeah. Good.
So hemodynamically, everything all right?
Patient has been, we're showing it downstairs. Yes.
Why? Stop up. So we can see it. So we are 1 minute 30 seconds.
But that's a one lesion.
Yes, one lesion.
And now we are going to the second, which is further down. Yep. That will be much easier because that's a moderate calcium by my definition.
And you just crossed it, I think.
Yeah. Yep. One more polish or is it done?
Okay, leave it. Total close to 2 minutes, yeah.
Yeah.
Now we are just doing a polishing run.
No, not that far.
Okay.
You going to third lesion also?
No.
Yeah.
Right here.
Good.
I think third region we don't touch.
Good.
Right? Okay.
Yeah.
Now get me a run through for the LED and then I'll try to wire the diag.
No, excellent demonstration of the rotablator.
And more important now, that how is the diagonal? Is still there or not? Answer to me before even taking a picture that it's still there.
It will be there.
It's there.
Yeah. I would have expected some EKG changes had it not been there.
Right.
It's a fairly
Yeah.
large size, but hemodynamics have been just
Fine. Let's take a picture now. Little roughed up question is, do you want to go to no? Yeah, run through first, replace the rota wire, and then we go with our the fielder or whisper, which you want to do. And do you want to do it in the aleocranial view? Because aleocranial was very clear cut here. For
Needle. I need the needle. Anyway.
okay. So we're replacing our LED, our rota wire with the run through, which used we earlier, and get a fielder wire guy. Yeah.
The same fielder that we used.
Yep.
How is the tip? Okay.
Yeah, very good. Everything keeps going into the D1, occluded D1.
I mean, two more questions have come. One is regarding the speed of the rotablator and what anticoagulant are you using?
Yeah, so speed basically, we have always have talked about that now we are going to the low speed, which is 140 to 150, around 150,000 RPM. Although one randomized trial, there's only one randomized trial to look into two speeds. And there was no difference in MI and slow flow in 100 patient trial from Japan. But at the same time, what we saw in our practice that by using a slower speed, it does take ablation efficiency does go down a little bit, but it caused less slow flow and less perforation. And anticoagulation patient has in bivalirudin?
Yes.
Yeah. So we are still using bivalirudin. Patient was on, as I said, clopidogrel, PRUS 330 if everything goes well. Would you change it to a prasugrel?
Yeah. we'll
Although we have
change
shown
after
in our
this one,
papers
will
that
be
it
FU.
really doesn't matter. Because nowadays, it's all your intervention are so good that antiplatelet therapy has become, to me, not a mute point, means it's essential, but not important. And we'll show a few papers today again. That whole concept of stronger antiplatelet therapy, longer antiplatelet therapy, all has been going away.
Very,
You want
very
to put
sharp,
Aliquin? Yeah,
angulated turn.
yeah, yeah,
Probably
Get me a
needs a
venture
lot
ready.
more,
yeah.
lot
We
more
want to
wire.
dilate
Yeah.
first the LAD and then use a venture.
But the question is, do you want to go to LAOV once? Okay, one
No,
second.
this
Yes,
is
you're
going
there.
to the pouch. This is a pouch.
Right, right, exactly in the
So we
middle.
have to like here. Other
I mean,
thing
why
is,
should, I can understand the slow flow and all that, but why a lesser rate of perforation with the slow speed?
No, I think it just basically is that it's creating less friction, less
Channel.
heat generation. Yeah, those factors. Yeah, you want to see it?
It looks
Yeah,
to be in the right
yeah,
place now.
yeah. No,
no. Okay, I think we will waste time and create more.
Yeah.
yeah.
So we dilate LAD first.
So what we can do,
And
put up this
then-
wire distally, and so wire remains in the distal lumen, and
No,
then we
I
do
think
with
we
a
have to
balloon, and then bring back and then go. Yeah.
have to
No, I
use
know,
a-
but let's put this wire in the distal lumen. The question people always ask that now you're going to do a dilatation. So I say always put your wire or the side branch in this situation in the distal. So you are still in there, not going through those cracks. Balloon, yeah. And monorail venture, right? Or over the wire?
monorail.
Monorail venture.
Oh, you
Yeah.
mean I may want to change it?
Yeah, no, later. Monorail is good. Okay. Okay, now Anu is trying the run through, which is, this kind of angulated will be very tough for run through. But since we have been using so much, we got very good at.
My thought was a whisper wire.
Yeah.
But
So I think that probably will be the next wire.
Mhm.
Should we go to aleocranial?
keeps
Where we
going
see it, bell?
keeps going into that pouch, no?
Yeah.
Yeah. So give me the balloon.
Good. Here.
Plus, a
Right.
significant disease in the
Play.
just before that is not
Right,
allowing the movement of the wire. So I
Yeah.
think we need to dilate it. And
Bet you
then
the direction of the plaque
And
takes the wire.
question is, do you want to put one stent distally? And because we're going to put two stents here.
okay,
So, okay, give us a 3032.
okay, then you
Promus?
have double wire there.
Yeah. No, but that time we just pull back. No. Good. Leave that wire. Yeah. Okay, going up.
Mhm.
Somebody has been very observant, Samin, in asking that
Done.
Yeah.
you would be using the same stent as was used for the RCA.
That is correct. Absolutely. Yeah. So we always try to, because, once we have publication that we've put into the same category, otherwise we have to exclude those cases. So we try to 16.
Dilate,
Yeah.
yeah.
Good. So we try to use as much as possible. Now, if you would have patient comes back in even 1 month, you start seeing some thrombus or restenosis,
Stop here.
then we'll definitely will change it. But if not, then we'll keep the same way.
Okay.
And let's say this patient comes back with a circ stenosis in 2 years and 2 stents remain good, we'll still use the Promus even at that time.
What Promus you took? You have a stent?
Yeah, 3032.
Too long.
No, that's okay. But you need 2 of them anyway. Yeah.
No, but you don't want to overlap at
Good.
the. Okay, some die.
Looking good. Looks more like a 325 or a
Yeah.
35
No,
actually.
3 will be okay, but we can post dilate. But now at least with the lumen open, we put stand there and pull back the wire and just try to manipulate in your diagonal.
Diagonal, yeah.
Yeah.
It's a fairly large diagonal actually.
Yeah, very diagonal, yes. Okay. You want it longer than 32?
Shorter, because proximally I wanted a longer stand.
Yeah. Then we still have. We'll look for a
I don't
3.5 32 also.
No, I don't think you need 32 now. After that.
So 32 or 28. Bring both of them.
No, important is distal left main. I think you need to image and see if distal left main.
Then
needs
yeah,
anything.
bring both 28, 32, 38.
No, 38 is too long. 32 maybe.
Good. No, nothing. Keep it with you. Yeah. Let's take the wire out first. 1 second.
Yeah, I will. Some die, so I know.
Good.
Okay, good.
Yeah. Good. Don't come completely.
Okay. Yes. Okay, go.
No.
In proximal diag.
16. Yeah, I think it made it. 1 second. Little die.
You're in the right place.
Yeah.
So the balloon kind of provided you a little anchoring and support there.
No.
No.
I'm just trying to save time.
No, I think
When
what it
something
did
else
is.
is going on, I'm
even
doing
that-
something else.
Yeah. Get a 2.515.
No, it just to change the way
The direction,
the
yeah,
significant
No,
significant disease in the in the LED before the bifurcation was not
Show
allowing the
them,
wire
show them.
movement. That's it.
Yeah, that's very important. Yeah.
So after the septal, if you see there, look at this after the septal. Look at the significant disease was not allowing wire movement.
Right.
So we dilated.
The
And then-
plaque morphology was directing the wire away
Yeah.
from the diagonal.
Right. Exactly.
Yeah.
Good.
So
Let's
that's
bring
what
back
it is.
proximally, open that
No,
area.
I did nothing. I was just like saving time.
Yeah,
That's
just
it.
here. Leave it here. Now, has that area opened up after the diagonal? If not, then we have IVL ready, a 3O IVL. I think
I think it's
3.5 will.
opened.
Looks
I
to
think it's
have
opened up.
expanded very nicely, yeah.
I
Let's see.
don't want to do SS IVL without imaging
We
also.
have to do it.
Oh.
Supporting, yeah. Okay,
No, I
so
understand.
let's take a
but
picture.
then
Yeah, let's
you
take a
have
picture.
to-
Yeah.
No, not here.
Good.
Not for this. Okay. You have to image first. then.
Picture. Yeah, we do the IVAS first. That's what I'm saying. Based on the IVAS only.
Looks very good.
Yeah. Let's take out. We have 2.5 balloon. No, open the diagonal first. Make sure your wires are. You can keep seeing them.
What?
Wire. Diagonal wire.
So Anu, there are two people who have mentioned would be, I'm summing what they have, they seem interested in understanding the distal left main with imaging.
Yeah.
Yes, we are going to do
Good
that.
observation.
Yeah,
Good observation.
absolutely.
That is the plan. In fact, we'll dilate the diag and then we'll image.
The distal left main.
Yes.
And the stented segment, as Samin mentioned,
Yeah.
post-procedural value of IVUS or imaging for that matter.
Yeah, that's right. Yeah. I think there is still an unexpanded area just after the diagonal, and the IVAS will tell us that.
The
You can do IVAS or OCT. Yeah.
more distal segment in the LED, just
Little more
bend,
now.
a bend. Yeah, I think.
Yeah. Yeah, I mean, we'll see. If ideally, those kind of cases, you should do FFR, and if need to be, then you put a stand there or leave it. So that we can decide. You need a compliant? Yeah. Okay, this is a 2.5, 15 watt balloon. Okay, they're going up.
Mm-hmm. Okay.
Oh,
down.
mini track. Wow.
Down.
NC track.
No. This is NC.
NC merge. Yeah, it's an NC merge. Yeah.
Looking at this, this is Boston.
Hmm.
Okay.
Yeah. I'm going up, covering the ostium now, and we are going to 16 atmosphere.
Okay, how the IVUS?
Look for a 2.516 also, but keep that stent ready for later.
Another
Take a
person
picture.
who's been observing a lot, he says, is mini crush your preferred bifurcation technique?
That's it. Actually, Vishal is looking at what, 2000 bifurcation cases? How many you have done so far? Yeah, the 1800, and they are looking all 1800 angiogram for last few months, and based on what technique, what will be the outcome, what is the MLD of the side branch with a mini crush, with DK crush, although we in our lab, it will be 75-80% mini crush for the two stent technique, about 10-15% will be a DK crush, and then followed by a little bit of tap or a step crush or reverse crush if they're radial and 6 French. Very rarely we do culotte.
Many years ago, you were doing a lot of SKS, which now
Yep.
has become different.
Yeah, bye-bye. SKS, bye-bye. All right, let's go. Okay, the imaging guru, tell us, is unexpanded stent after the bifurcation or not? I mean, unexpanded area after the bifurcation or not?
Sure.
Because they're warming up the IVL.
Okay, can I check the image?
I
Yeah,
think
it's
it'll-
in the.
Make it to the main screen. Good. Flush a
Okay,
little
it's
bit. Good.
instant. Okay, I start fullback.
Yeah.
It's coming. Yeah, looks expanded. Yeah.
So at the level of the bifurcation, I think will be fine.
No.
Let's see.
Yeah, we can see the calcium behind the stand, but stand is very expanded.
You're still in the stent.
Yeah, still in the stand. Good area. Yeah, here now came to the NATO. Now
That's
I
the
see the.
diagonal.
Yeah, this is the wire diag.
Whoa.
Yeah, you can see the second wire. And now come to the proximal LED part.
But
Yeah,
a lot
looks
of
like-
cut in the calcium.
Yeah,
Yes.
true. And now it's a big branch.
To the IVL.
Yeah, Flux LED also has some
teach
plug.
people the right thing.
Okay. Okay.
Yeah, looks borderline. Now come to the left main bifurcation. This is this left main.
Fluoro.
Yeah,
See the
modest disease there.
Yeah, true. And
Yeah, but I think we are
But very
okay.
nice,
Yeah,
very
we can
nice
leave it.
lumen. Yeah, very nice
Yeah.
lumen.
Yes.
oh sure.
why we don't have a IVASCO registration with NGO? We don't have it, or they don't make it yet?
No, Philips has it, but we don't use
Yeah.
their IVAS.
Yeah, but that's Philips IVAS is. But I'm saying, but they had to do it. Boston Scientific has to do some good things.
I like it. Yeah, this is a distal left main area is like more than
6.58.
six. Yeah,
I think
there's
can
a
be left
plug,
on.
but yeah, area
Yeah,
is more
leave
than
it
six.
alone.
Sure.
Okay, see the last picture?
Now at the level of the diag, let's
Yeah.
go back to the level of the diag, and I think we have done good atherectomy and
And
balloon.
bring, no, I mean, I would say angiographically, what harm it to bring the stent in the mid left main? Tell me. There's no harm. This patient may come back in 6 months, otherwise progression of that moderate left main disease.
Okay.
And circ was very small, not a big one anyway. I think we should just put a stent up to there. So let's go again. Distal to the diagonal where we had just did the balloon. Tell us the MLD there.
Oh shit.
Another
Right.
Not
related,
MLD. We are
relate-
asking, has the calcium been modified?
Okay.
Yeah, I think
Exact
so.
question.
Yeah, there's some like 2 quadrant calcium, but I saw the clock, like here. So I think it's well modified. I think we
You
can.
can
put-
see nice cracks.
Yeah, nice clocks.
But should we supplement this with a cutting balloon then, not IVL?
I think no need to do.
Huh?
I
But
No
you're
need
okay.
to do anything.
Okay.
Based on
All right.
imaging and
Good.
our experience, no
Good.
need to do
Okay.
anything, just place.
Let's get the stents. Okay, let's go where the money is.
Samin, the question has come, any role of FFR here?
No,
At
not
this
now.
time, no.
No, not now. Not now. Why?
FFR.
Because, no, because we know the lesion is still there. So remember, FFR will be after you put the stent.
No, I don't know
Then
if
for
the,
the distal.
the reference is regarding distal left main or
No, but-
something. I'm not able
Oh
to.
no, but right now nothing till you already have disease LED. FFR
So
could be
you're-
value.
You're,
First
you're
you have to
going to stent the
revascularize.
distal left
Yeah,
main?
left main. Yeah.
Okay,
We should do it.
got it.
Okay, 3.538 or what you want?
Yeah, 3538.
3.538. Pro
And
much.
then,
Yeah, it's a good
25, right? 16.
Yeah, and 2.516. Yeah.
25 first. Right branch always first.
All right.
Okay, let's play the mini non-left main mini crush in the side.
Go.
Felipe. Good.
Yeah. proximal LED size is 3.8, and the left main side is like 4.3.
Okay. Now we can post dilate with the 4 there.
Sure.
Connected different, right?
Good.
Okay, good. Now 3.5, right?
Yep, 38.
And then get us a 4.0,
4012
yeah.
or 8?
8 maybe. Let's see how.
Yeah,
how
no,
much
4012 will be okay. 4012 high pressure balloon. So we have a 7 French VL 3.5 Mark 1. As you see that Mark 1s are very soft guide and with the preferred guide in our lab because less trauma, guide catheter trauma. So just to say of the 4,000, the PCIs we do roughly, we will probably every year we'll get a 2 or 3 maybe guide dissection. And of the 3, the 2 of them will be because the mark was not available, we use some other guide catheter.
Okay, now die.
Okay. Those are always stiffer. So we always tell everybody. And then of the 3, 2 probably will be the radial. So we have seen this correlation.
No, all will be radial. Okay.
All well, no, there was other case was the groin was that RCA.
Someday.
Yeah.
Okay, good.
Pull back few millimeter. No, pull back
No, I
few
think we're
millimeter.
good. I don't want to.
Yeah.
Mega
You
crush.
too much overlap. No, way overlap. No, I'm saying main LED.
Oh, LED, forget.
Yeah.
That's why I was thinking 38 would have been too long. I'm focusing on the diagonal.
Yeah,
The rest
yeah.
we can move later.
Yeah. No, but okay. Ideally, if you pull
Yes.
back, yeah, let's go. Pull back the LED few millimeter, and we are going to do it now. The diagonal. Good. Ready?
It's too much. So some
good.
die in
That's
the
good.
left
That's good.
vein. Look at that.
Yeah, that's
Too
fine. That's
much.
okay. Okay. I'm doing the diagonal now.
Okay.
Happy?
Well, yes.
Okay. All right. Diagonal 2.5, 16 Promus, 16 at 16 atmosphere.
Down. Give me a new fielder. I think this is, we used it
Yeah.
a lot.
Yeah.
Cross the LED, cross the diag. Recross will not happen.
Okay. Yeah,
So-
it will not happen. Your wire is. So yes, if you would have not gone with the fielder, I would have, my second wire would have been the whisper.
Right.
You want to go a little
Too
more?
long.
Yeah, that's fine. Good. Go on.
Wait. Where is this? So this one. I'm going in a little bit. Okay, now die.
Yeah,
It's a lot
fine.
of overlap. Some die. Good, right?
Yeah,
Okay.
very
go
good.
up.
That position looks good.
Yeah, go up.
This is a 3.5.
Yeah,
3.5, yeah. And we saw that proximal LED is 3.6 and left main is 4.2. So we average, we just 4.0 do in between. You take both the wires and this one out. They're done. They live their life. Ready?
Did you pull the other wire out? Probably.
No. Other wire is good so far. Throw away, guys. Let's do one more inflation.
No need.
No,
I mean-
overlap. Go inside.
It's a nice overlap. Lot.
No,
of
no, no.
overlap.
Overlap balloon. Yeah, good. Just moderate pressure.
Okay, now get me the fielder and let's recross.
Right here.
And I think we will need a 2.0 because of the angle and the calcium. We will go with a 2.0 balloon. You want to bring the
2.0
pink
compliant.
balloon? Yes.
Very nice demonstration of the app.
Okay, ready? Ready?
Yeah.
Nice.
So question is for the main vessel. Do you want 3.5 balloon? I think LED 4.0
No, I
may be
think
too
we're
big,
good.
no?
For where?
For LED, that area, the bifurcation is to still open more. Throw it. Once you wire it, then we'll go on our presentation because so we can finish in time at 9 o'clock.
Okay.
But wire first because wire is the key. Key is the wire and put your small balloon, do the kissing, and then when you're ready for the main IVAS final, will come back.
We'll do it and we'll show it to you later.
No. They want to
Cannot
see.
Wait.
Yeah.
We'll close it. Yeah.
No, we wait anytime. We can interrupt. Didactic part can be interrupted.
What wire are you going with now?
The fielder again.
Okay.
Somehow D1 is preferred
Yeah, little lower
branch.
out there. There we go.
Balloon is ready.
Excellent
Good.
job. Excellent.
Good.
Okay.
Okay, so tell us about this new pink balloon they call.
U for a magenta color
Is a U4 of a,
is a Metronic. Yeah.
okay, compliant balloon, right?
Yes.
Okay.
2 at 12. We are testing it. And then you want 3.5 LED?
Yeah, yeah. I think
3.5 15 high pressure for the LED.
and 2.5 we have it already. Yeah.
Yes, we can use the same one.
Yeah. Good. Good. 3.5 balloon. Good.
Okay, go up.
20. Good. Ruptured. Bye-bye. Ruptured. Bye-bye. Good. Let's go 2.5 we already have now. No, go with the
No,
ruptured
I
balloon.
know. I wanted to make sure because there's I can still feel the calcium spicule.
Okay, get 2.5 or we have the balloon before. So these are the soft balloon. You'd go beyond 16. They rupture. Most of the compliant balloon, I would say rupture rate, go more than 16 atmosphere is almost 25%. Yeah, 2.5 now, which we used earlier. We're going back with the same.
Mm.
Yeah.
This is for the final kissing.
Yes.
Yeah, final kiss, yes.
2.5 non-compliant to the diagonal, and then we are going 3.5 to the LED.
The question
Then we are
is,
going to do LED left main with 4.0.
the
Yeah.
2.0 previous balloon which you used
Yes.
Make the room, yeah.
right, that is basically to open that particular single strut.
Oh
Yes,
yeah, because
yes,
remember
yeah,
this is the angulated vessel. Your other balloon
And
would not have
calcium.
gone.
The question is
Yeah.
that a standard practice you would have or
In
Not
a
all the
non-left main.
time in a calcific vessel and where we already know this diagonal was not easy to wire, we would do this.
excellent.
It's not mentioned in the app. In the app, we say just go with the compliant or a non-compliant. We would say quarter size smaller, non-compliant, because easy to cross.
Yeah.
With left main, we will say 1-to-1 in the circ. So now this is in the LED, 3.5.
Good.
Okay.
Going up.
Now go diag first.
Yep. Always diag, you open nicely at 16 atmosphere.
Yes. Okay, good. Down. LED. That was our concern that you felt it was not open. 18. Good. Yeah, happy? Yes,
Yeah,
there?
yeah. Both 12.
Yes. And then I'm going to do left main and then IVAS. 4.0,
Yep.
left main.
Good.
Okay.
You can use
down.
both of them simultaneously. They will be same. Remember 3.5,
Did you open
2.5
4.0?
is 6. No.
No, it's opened.
Oh, it's open. Okay. But just show the picture so that I can go with my presentation.
Okay.
Come back in the guide, take a picture.
I'm going to take the diag wire out.
No, but let's take a picture and then take out in case there is a dissection display, which is not.
No. Which
Good.
very
Okay.
good without.
All right. Let's go with the fantastic results so far. Require little makeup now. The main thing have been done.
So
Put
you want to
little-
see IVAS live?
Yeah. Okay. Let's go to the presentation now. Good. So we were there. So two, as our the presentations always, two of them, the recent international publications. One is the drug-coated balloon versus DES in STEMI. Then Sydney 2 study of DAPT in complex PCI. And third is the DAPT after PCI in high bleeding risk, as we talked about antiplatelet therapy. Second is a very important paper, which is the CME. They consider that as a main part, the cover page of the JAC intervention, data from Mount Sinai, which is a correlation of the validation of the UK BCIS chip score to predict 1-year outcome in contemporary US population, Mount Sinai Hospital database data. And so let's go to the first one, drug-coated balloon. As you know, drug-coated balloon is coming up. This is the data, not a randomized trial. They do a case control in a STEMI patient, de novo disease, and second generation with the 452 drug-coated, 687 second generation DES, and basically found up to 5 years up to 5 years, as you can see here, identical outcomes of mortality
Good,
and in the propensity match group also. So overall, identical outcome of the drug-coated balloon at 5 years compared to DS in STEMI patient. This was a paclitaxel drug-coated balloon. Second, if you see that what were the predictors, drug-coated balloon was not a predictor of subsequent event. It was age, heart failure, CAD, and of course your frailty score of the mortality. So this basically puts it together. That 3-year follow-up, a median with a total 5-year follow-up, propensity matching, no difference in all-cause mortality, and net adverse cardiac event of cardiovascular mortality, acute coronary syndrome, stroke and TIA, major bleeding, or unplanned target lesion revascularization. So basically, we have another device now. You want to worry about not giving long-term antiplatelet therapy, can start using a drug-coated balloon, which soon will be available in America by end of this year. The second is P2Y12 inhibitor monotherapy,
We are ready
single
for
versus
IVUS.
dual antiplatelet therapy after complex PCI. With defined complex PCI, everyone has a different, this paper defined, more than 3 vessel, 3 lesions, 3 stents, 60 millimeter length, bifurcation with 2 stents and CTO. Those are the 6 category of the complex PCI. And what basically they did that the patients who got 1 to 3 months of DAP, after that they became single monotherapy compared to your standard standard DAP in complex and non-complex, some of the difference in baseline which will be. And very important point is this slide. Primary endpoint, efficacy endpoint, which is the ischemic, basically showed that once your complex lesions, remember complex DAP and complex DAP with monotherapy. So complex monotherapy and complex DAP, complex disease have a higher event rate compared to the simple non-complex lesion. One. Second point was whether you continue monotherapy or dual therapy, there was no difference. But what was difference in the bleeding endpoint? Bleeding endpoint was significantly lower in the single therapy group. All-cause mortality, myocardial infarction a little better, stroke no difference, and stent thrombosis also no different, with overall net adverse clinical event better in terms of using a single therapy irrespective of the complex lesion. So this basically was whether it's a individual complex lesion, no difference, and whether 1, 2, or 3, no difference. So basically tells you that after 1 to 3 months of antiplatelet therapy, 1 to 3, that you can stop it. So key is what we have been taught in the past, more complex lesion, rather you should use longer antiplatelet therapy, and answer to that is no. Based on this study, this is the central figure, complex PCI on the left side, non-complex on the right side. On the top, incidence of various complex component, and basically primary efficacy, key safety endpoint, primary efficacy endpoint were similar, key safety endpoints were higher in basically the patients who got dual antiplatelet therapy, and which lead to the overall net adverse clinical event. And this basically was the data. You are ready for IVUS?
Long time.
You're doing it or you're done?
Done once, repeating again.
Okay, let's go back to IVUS. So I think this is important because I'm sure everybody wants to see the live
IVUS
IVUS.
full screen, yeah.
Okay, start to work.
Yes,
IVUS on the main screen,
It's coming.
please.
Yeah, it's this LED native.
Yeah.
It's coming back.
Ah.
Still outside a stent. Yeah, good lumen. Yeah, healthy vessel. Some fibrous block. Yeah, this is the edge of the stent. Yeah, looks nice. Yeah, well expanded. No malposition. No dissection. Yeah, looks well expanded.
Super
Yeah,
expanded.
super expanded. Yeah, like round shape.
Yes.
Like nice plaque modification. Nice.
So when we are at the level of the bifurcation, that's where
Flush a little bit.
flush.
Yeah.
Yeah,
Now
it is
it's a
flushing.
mid part.
Are we at the
All
diagonal
well
yet? No.
expanded. Yeah,
Yeah,
here's all.
reaching there, reaching there.
Yep.
Yeah.
Yep. Symmetric shape. Great area.
Okay, diag is coming now.
Yeah,
Yes.
now I see the blanch. Yeah, here is a kind of under, but it looks the area is good.
Good expansion.
Yeah, yeah. Now this is
Nice.
the septal and the diag one. Now coming to the flux LED. Here's also well expanded.
Very nice expansion,
Yes.
circular. Remember, a lot of people believe that eccentricity of the stent expansion associated with higher restenosis. This is such a nice circular lumen.
Look at the left main
Yeah,
also.
this is
Beautiful.
yeah, perfect. Yeah, proximal is
Beautiful.
normal
Wow.
position. Yeah.
All right.
No dissection.
Very good. Let's go back to presentation. We did a fantastic job on the angiogram. Let's go to the fantastic job we do it in the presentation. The second is the dual antiplatelet therapy duration after PCI in high bleeding risk. A meta-analysis, 3 months versus 6-month DAPT, kind of extension of same, and they took 2 bleeding risk scores. One is the precise DAPT, which is basically if more than 25, age, hemoglobin, renal function, white blood cells, and prior bleeding. Those are the component of the precise DAPT, and the higher bleeding risk based on the ARC definition, which are there: age, renal disease, liver disease, active cancer, anemia, low platelet count, prior stroke, bleeding diathesis, prior bleeding, and non-steroidal use. So they compare basically 1 to 3 months of DAPT with the 6 months or more of the standard DAPT, and basically found these are the trials, as you see on the left side, and major and clinically relevant
Less
bleeding,
than 1.
basically lower in abbreviated DAPT versus standard DAPT. And these are the patient high bleeding risk. Now you say, well, that's okay. But what about the MACE? MACE right here at the unity. Abbreviated DAPT versus standard DAPT, no difference in the death, MI, and stroke. Very, very important observation, similar to what I showed earlier, and basically landmark analysis that after 3 months, when you stop the DAPT, is there a difference in the single monotherapy versus double, which we learned already? There was no difference in shown here. And abbreviated versus individual endpoint. So basically they found the decrease in the 24% major relevant bleeding, major endpoints, and 21% decrease in death, similar ACS and acute coronary syndrome. So short up in a bleeding patient, high bleeding risk patient is absolutely essential. So this basically support that. So this will put it together. Let me take you through complex PCI on the top. 1 month DAPT if high bleeding risk, de-escalate to clopidogrel monotherapy and continue clopidogrel monotherapy, take away the aspirin. Second, 3 months DAF if patient has the average ischemic risk and not a high bleeding risk. In that case, as based on the twilight of Roxana Maran, de-escalate to ticagrelor 90 milligram twice daily, and then you can go to the 60 milligram twice a day based on the Pegasus trial for 3 years after 1 year. Third, 12 months DAPT, particularly with acute coronary syndrome, which is high ischemic risk and low bleeding risk, because there you can make it 6 months if stable CAD, and then continue DAPT if no bleeding during prior 12 months. So that's what some people believe, that long-term DAPT may be beneficial, particularly patients who are high ischemic risk or reassess bleeding, but based on the data which we showed today with a complex PCI, there was no difference. So there is the things are evolving. So let's go to the focus review of the month. That is the validation of the UK BCIS CHIP score to predict 1 year outcomes in a contemporary United States population, Mount Sinai Hospital data. Look at the right side, it's a mock and CME. They really made this a very highlight paper. We have question answers. We have the verbal recording of what we found in this particular study. But more important is you can get the mock point once you do a CME with this paper. So what we basically, if you recall, about last year, there was a CHIP score came from the BCIS. So this was the first time they had a 7 patient factor and 6 procedural factors which correlated with adverse outcome. Increasing CHIP score, bad outcome which was shown with a Mackey per score and cumulative MACE, age 80, female sex, prior stroke, prior MI, PAD, EF less than 30, and CKD. Then in the procedure, left main, PCI 3 vessel, dual arterial access, mechanical support, lesion length more than 60, and rote ablation. And what we divided that time, let's divide these patients which are not part of the paper, that we divide in 3, low risk, intermediate, and high risk. We divided low risk 1 to 2, intermediate 3 to 4, and high risk 5. Why? Look at the high risk. All of a sudden 1 become 4, and then continue to increase. So with that note, what we did is a Mount Sinai analysis of 21,000 patients. We put into about 21. Yeah, no, oh, sorry, 25,000 on the top, then they excluded MI, but analysis was on the 21,000 patient from the 25,000 patient with the 5,000 score 0 8,000 score 1 to 2, low risk, 4768 3 to 4, and 3,000 score more than 5. And we found basically these are the individual percentage of scores of cases. Of course, the procedural characteristics will be different in each group. Higher the chip score, higher is the complicated medical history, more devices and so. But this is the key. Basically that if you take in hospital outcome with an increasing chip score, your event increased from 3.2 to 13%, and bleeding also increased. So not only it was a MACE, also the bleeding. Now say that was they have shown it, but let's say what we took it further at 1 year. Look at the 1 year. Each group of component of the chip score, death, MI, stroke, all cause death, MI, PVR, and major bleeding all have a nice correlation, except stroke did not have it. So every one component of the MACE endpoint and bleeding correlated with a high chip score. And we have a 1 year data. Original paper of the BCIS was only 1 month. And because we have the 1 year data, I can tell you this paper was so rapidly accepted in JAC intervention, like within 3 months it was published. We submitted in November, we got approval in April. Sorry, what's saying?
TVR also. Not
Yeah, TVR. Yeah, TVR, every aspect, and this is very nice. 1.7, 3.0, 6.1, and 12. This was very nice, this registry and correlation. So this puts to the multiple of the risk scores, the CHIP UK BCIS score last year, and adds to Mount Sinai validation of BCIS CHIP score. So this is very good. Only question comes, what to do now? Should you use it as a quality measure? Should you use it as a prediction? So I think this is basically tells you the resource usage. The higher the chip score, maybe more complication, so you be better prepared. So let's pull it together now. Paclitaxel drug-coated balloon versus DS in STEMI, 1 thumb up. Single versus DAP duration after complex PCI, double thumbs up in this day and age. Short DAP duration after high bleeding risk patient with a PCI, 3 thumbs up. And lastly, a recent report from a US PCI center, Mount Sinai Hospital, validated the impact of UK BCI chip score in prediction of 1 year MACE. There was an incremental increase in MACE and bleeding after every increase in chip score. Therefore, chip score is a simple, valuable tool to predict short and long-term MACE and major bleeding, and can help to stratify the management and triage of these complex cases and resource utilization. We are planning to use this score in our cath lab report generation, so may justify patient need to be admitted overnight for 2 days and so we'll use this in our practice soon. So now let's put it together. 3 questions. Following statement is false regarding the outcome of paclitaxel drug-coated balloon versus DS in STEMI. One is a similar MACE rate, similar stent thrombosis, higher unplanned TVR, similar major bleeding between 2 groups, and similar acute coronary syndrome. Answer is everything was similar, so higher unplanned is false. So TVR was same. Second, following statement is false regarding the results of Sydney 2 study. Collaboration of antiplatelet monotherapy versus DAPT after complex PCI, similar mortality, similar MI, similar stent thrombosis, similar MACE, and similar BARC type bleeding. Answer is E, wrong, because there was lower bleeding in the monotherapy group. The last, the UK BCI chip score validation revealed significant correlation of higher MACE rate component with higher chip score at 1 year, except mortality, MI, bleeding, stroke, and TVR. We clearly said stroke. No difference in the stroke, but everything else is there. With that note, we complete our presentation, and now we'll give you a chance, maybe last note from Dr. Keeney and Anno, and then you talk about MedStream, how it has shaped the world.
Sure, I was a question, your last thing you said. So how you want to change patients?
No, patients with a higher
chip score?
What
do you want to do?
No, more important that those patients should have bad, they should be admitted.
No, I'm not talking
more
that.
antiplatelet
After
therapy.
they go home, when they're going home, what is the change that we are going to
No, but I
have?
think you have, what we can control is the acute treatment for those patients and more stronger antiplatelet therapy.
No, we're just saying we don't need more strong.
No, but this subgroup maybe. This subgroup maybe. Yeah.
So I don't
So,
know. I mean, I think lipid management.
And aggressive lipid management also, yes.
We are showing? Yeah.
First
Sorry.
of all, Sameen, congratulations on this outstanding paper, 25,000 patients with the CHIP score for and followed up for 1 year. 2 follow-up questions which came when you were mentioning about the further application of the CHIP score. could it even be that a higher chip score would mandate imaging? And the second thing is that could this be used even for reimbursement? I mean, you mentioned
Absolutely.
about, yeah.
Yep. That question actually was part of the review with the editorial. They talked about it, quality and reimbursement, but this is since it is only one data, till we have more validation, we should keep it there. So right now we use it, but don't make it a quality matrix and reimbursement pattern. Absolutely, they're very important. Now in this paper, this is BCIS. Key was only IVUS was used or imaging was used in 14% of those patients. So they did not come up as a negative or positive in terms of subsequent predictors. So it was not part of the chip component of those 7 clinical and 6 angiographic criteria. And we just duplicated that. We didn't add any of it because we had published 2 other papers on a various chip scores. But this one was, we just took that and duplicated with our data.
So our total contrast volume was 110 cc of dye with the air karma of 0.9. So one other app that we just released recently within this month was IVUS app, IVUS Aid. Again, free to be downloaded on Android as well as Apple, but we have a web app also. So the key features, this is you see that the principles of IVUS image interpretation, which is very important for many people to understand what image is teaching. Case reviews, several cases with the detailed case presentation and annotation also inside there. 50 quiz, and we can test they can test their knowledge and as well as recommended reading, and we'll keep updating with any new publication that comes. So this is what you see there: lesion morphology, annotated and unannotated, giving an example. Then lesion morphology with pullback, that you can see how each lesion will look like. And these are all the cases. All these cases are from here, Mount Sinai. Many of them are the live cases that we have done, showing image of each vessel. Yes, then this is one of the case from the web app showing the entire case presentation, discussion, angiogram, IVUS, final angio, giving steps of the procedure also. And these are the quiz that you can see. There'll be question. We'll give a case. There are questions. You choose the answer, and then once you choose the answer, we will give an explanation why that answer is correct. This is what we are right now, and the next app that will be ready will be the device aid mobile app. Should be coming in the next month or so.
Anu, congratulations on this app. I think not only would it be a great way to master IVUS, but also excellent board review. I think with putting those questions, I think can be extremely helpful. So congratulations on this to you and your team.
Yeah, this has actually probably the most popular after Bifurcate. We already have over 1,000 downloads on this IVUS app. Yeah.
Fantastic. Congratulations. Now, as we mentioned at the beginning of the case, here is providing you an update on MedStream 360.
This is really going to be a unique platform. People will be able to tune in and see interventional live cardiology cases from around the world performed by some of the world's best operators. The real advantage of this is that they'll do 9,000 cases spanning the whole spectrum of interventional cardiology.
For MedStream 360, we'll be extending 24-hour live cases so that you can watch cases in your own time zone, time frame, at your own convenience.
MedStream 360 is a transformation in medical education. With MedStream 360, you can see wherever you are, in your office, at home, in your computer, in your iPhone or your laptop or your iPad, any case in any topic whenever you want. And not only that, you'll be able to see the best operators from around the world sharing their live cases with you.
There are several unique attributes of MedStream 360. We have no moderation and there is no time restriction. The majority of the cases, an overwhelming majority of the cases, are viewed not live but archived cases. So to enhance your viewing experience and to customize the archived cases to your requirement, we have assembled an army of physician video editors who have been experimenting with different formats. All of this is being done to enhance your experience and to make MedStream the most beneficial.
Concept here is to provide easy access to more live demonstration cases to more physicians. I think live demonstration cases are probably the best way to learn the nuances of our field. And the more we can do to bring cases of interest to our community, the better we'll all be. This is a great way to exchange information and to keep up with the latest in interventional cardiology, period.
So I look forward to welcoming you to MedStream 360, and please give us your feedback. We hope you enjoy it as much as we're enjoying putting it together. Thanks very much.
So now to update you on MedStream 360, as you saw in the video. This video was made almost a year ago, and it is exactly what we have been able to achieve. 24 hours of uninterrupted live cases from 12 centers in 8 countries. You can watch it starting at 8 p.m. on Eastern time, and this would continue till 8 p.m. Wednesday. The live cases can be watched on our website, medstream.com, and very soon we will be transitioning straight watching on YouTube. 2 options, you can watch the live case entirely. Again, these are uninterrupted, no excessive moderation, no gagging of physicians, and either the live case for 24 hours uninterrupted, or you can visit the website and watch the full case or its edited version, exactly as the video mentioned. An army of video editors converting a 60-minute video into a 20-minute and thereafter into 5 minutes and even shorter versions for social media. In the 4 weeks of having performed MedStream 360, 78 complex interventions have been done, 53% complex coronary, including left mains, bifurcation, calcified lesions, and many antegrade and retrograde approach CTOs. 39% structural cases with the variety of TAVR cases, including with several new aortic prostheses from different centers around the world, and of course a lot of mitral clips, sinus venosum closures, coarctations, AST closures, Watchmans, and many more structural cases. Plus about 11% of the cases have been peripheral, including some absolutely instructional and beautiful cases from Mount Sinai, New York, with Dr. Prakash Krishnan and his team. Many people to thank for MedStream 360. Most of all, Danny Trottier from BroadMed AV. Without Danny's help, this was not possible. I have watched Danny work meticulously 24 hours, uninterrupted, non-stop, tackling every issue and producing for you top quality television style, television quality broadcast. So please continue watching us. Once again, that is starts Eastern time at 8 p.m. on Tuesday and continues for 24 hours. The sites included are Harbin, Nanjing, Chennai, New Delhi, Copenhagen, Bordeaux, Madrid, Montreal, Mount Sinai, New York, Buenos Aires, Sao Paulo, and finishing with Thousand Islands in California with Dr. Saibalkar. I hope you will find it extremely interesting. The sessions are also interactive. Please keep sending your questions, and look forward to seeing you during our next broadcast, which is on May the 23rd, 8 o'clock Eastern time in the evening, beginning from Harbin, China. We'll see you then.